Irish accent. The second thing is that for everyone attending, you will receive a certificate of participation. So we can send that to you at the end. So again, just to say welcome. My name is Emmett Moriarty. My background is in healthcare management and investment. I'm based in London, but I've managed healthcare facilities around the world, and I'm advising IFC on its benchmarking project. I'm also a director of a healthcare company called HHI, which operates 3 hospitals and 40 clinics in Kenya and Uganda. So let me just start by sharing my screen. So here we have the moment of maximum risk. So hopefully everybody can see that. Okay, so let me just talk a little bit about how we got to this point and why are we talking about improving operating theatre performance today. So some of you may know that IFC for the last few years has been running a healthcare benchmarking service. Now, why did IFC, get into this business of healthcare benchmarking? The primary reason is that demand came from clients, hospitals, healthcare companies operating in emerging markets, Africa, Latin America, Middle East, Asia. And many of these companies feel that they're operating in isolation. They don't know how their performance compares with others. It's often very difficult to get good quality data in their local markets. And even where they feel that they're operating very well with good performance, good quality, and so on, they didn't know how they compared with hospitals in advanced economies like the US, the UK, and so on. So that really got us thinking about doing this, and we worked with 18 companies back in 2021, and I'm just going to cut a very long story short by saying we came up with 185 metrics. We worked a lot on definitions and so on so that they were as consistent as possible. And those metrics are in 4 buckets: financial, operational, quality, and surgery. And by that, I mean short stay, day case surgery, mostly actually around the operational. So financial, as you would expect, revenue, profitability, and so on. Operational, number of cases per theatre, number of scans per CT, number of dialysis sessions per dialyzer, and so on. HR ratios, staffing ratios, etc., etc. Last year, 2023, we ran this service again with 50 companies, 50, covering 162 hospitals. And we threw into the mix, hospitals from the UK, US, and other places. So we got a lot of data. And when we spoke with the participants, one of the themes that came through again and again and again was operating theatre performance. I don't need to tell people on this webinar, operating theatres are the beating heart of hospitals. It's where things happen. It's where bottlenecks occur. It's where dangerous events can occur. So there was a lot of interest in finding more about this area. And maybe I'll just share a little bit about some of our findings specifically relating to operating theatres. So this graph, if you look at the left axis, shows the number of inpatient surgical cases per operating theatre. And we can see that this ranges, from very low numbers, less than 300 or 400 on the left, up to over 1,000 on the right. Now, common sense tells us that some of these hospitals are doing very complex cases and some are doing very routine. Some of these hospitals are, mature, some are new, and that explains some of the variance. But when we dug deeper into these data with the participating companies, what we actually found was, that most hospitals are not so different in this group. They're mostly doing, routine type surgery, general surgery, maternity, gynecology, urology, and so on. And there were a lot of unexplained differences here. And by the way, just while I'm talking on this point, you might be thinking, well, why is IFC interested in doing something like this? It's clear why healthcare organizations are. IFC is, of course, as well as a financial organization, a developmental organization. So if healthcare assets are not being used, there's a cost to patients in that. They pay more, either directly or through their insurance and so on. It also means that there's just a lot of healthcare equipment and assets that are being underutilized in emerging markets. And anyone who's traveled around these markets will have seen that. Now, we're all familiar with the news these days. USAID has cut its aid. Something similar has happened in the UK where aid is being cut. So there's a big focus on healthcare organizations, both public and private, having to do more with less. So that's where IFC is coming from in all of this. So let's just look at a completely different type of analysis here. And this is surgical site infections per 100 inpatient surgical procedures. So I chair the quality committees on some of the companies that I'm a director of. And I guess the first thing that strikes me here is about half of the organizations submitting data submit zero, zero infections. Now we know, and anyone who reads the Lancet Commission on quality and so on, that surgical site infections in developing countries are 6 or 7 times higher than in high-income countries, and yet we see these very low numbers. So what we saw in this is that there seems to be still just a lot of work to do from the quality side of things, to improve patient safety outcomes in surgery. Uh, Another graph relating to quality, unplanned returns to OR per 100 inpatient surgical procedures. We know again that the complication rates in developing countries are much higher. I mean, in Africa, for example, where I'm a director myself, twice as many Africans die post-operatively compared with the rest of the world, not just high-income countries, twice as many, even though the patients are younger. And yet, when we look at the data, getting back to your third report, no unplanned returns whatsoever. So there's a lot going on here that we don't really understand, but which does say a lot of work to be done on quality. And this might be a good point to mention, and I probably should have said it right at the very beginning, that the benchmarking work that IFC does is just one of the strands in a community of practice. IFC also has a quality improvement work stream. It also has what's called EPIC, ethical principles in healthcare, a work stream. So the benchmarking is not a thing that stands on its own. It links very, very closely with the other strands. And finally, let me just show you, a very different analysis here. And this is day case rates. So for anyone who doesn't know, day case is when a surgery is performed, a patient comes in, usually in the morning, has the procedure done, and they leave on the same day. Now, don't worry if you can't read the typing here, but it's 18 common procedures. The yellow bar is the proportion of that procedure that is done as a day case here in the UK from the British Association of Day Case. surgery, the VADS median. The dark blue is the median of the 162 hospitals participating in our benchmarking club. Uh, and the sky blue is the upper quartile, so let's say the best performing. Now, if we look slightly to the left here, and don't worry if you can't actually read numbers, but one of these is laparoscopic cholecystectomy, which many of you will be familiar with. Now, lab coli, if you're a patient in the UK, 64% of those patients will be done as a day case. The median for the benchmarking club is 8%, so 8 times less, and the upper quartile is 20%. Similarly for hernia repair, which is to the left of this, in the UK, 78% are done as a day case. And by the way, not saying the UK is the best, we were just able to get this data quite easily. But the benchmarking club, it's 6%, so 13 times lower. And the upper quartile for the benchmarking club is 21%. So it's very interesting here, because in developing countries, of course, if a patient has to stay overnight, that can be quite a substantial cost to that patient or to their insurer. So this opens a whole new door, a lot of interest. I'm not going to talk about this now, but just to set the background, but we will be holding a separate webinar on day case surgery in a few weeks' time. So watch out for that. Finally, I'll just say that 2025 benchmarking round is just starting, so it's not too late. If you are interested, contact my colleague Jenny Zhao, CZHAOI5 at ifc.org. If you join, you get a database of all of the data. It's totally anonymized. Needless to say, there's quite a lot of sensitive data in there, so we anonymize it. You get that in different formats, Tableau and Excel, and also a report of highlighting the findings for your organization. The government of Japan still very kindly funds this work, so it is free to join, but we do ask that everybody submits the full suite of data. So contact Jenny if you are interested in joining. So I'm going to stop at this point, and I'm going to hand over to Dr. Adam Dahlia from the world famous, I would say, Mass Gen Hospital. So Dr. Dahlia is the Associate Medical Director of the Procedural and Perioperative Department at Mass Gen Hospital. He is also an Associate Professor at Harvard Medical School and a board-certified cardiothoracic anesthesiologist. Dr. Dahlia is a fellow of the American Society of Echocardiography and a diplomat of the National Board of Echocardiography. He's authored publications and delivered guest lectures on operating room and perioperative efficiency. His areas of expertise include the safety and quality of critically ill patients, process improvement in the perioperative setting, and clinical proficiency in mechanical circulatory support. So we're very lucky to have you, Adam. Thank you so much for joining us. I know it's early morning over there, so over to you.
Thank you. Can you see my slides?
Yes, you can see it just fine. Thanks a lot.
Great. So thank you for that wonderful introduction. Again, my name is Dr. Adam Dahlia, Associate Professor at Harvard Medical School and the Associate Medical Director at Mass General Hospital Procedural Services. So we'll jump right into it. Our objectives for today, we'll discuss the operating room or operating theater culture. I'll dive into data-driven analytics and how we use data-driven analytics to create that culture, foster that culture for efficiency. And then lastly, touch on a sample example of efficiency improvements and how we can take an underperforming area, service line, or part of the operating room and help them improve their efficiency. And then we'll round out with how do we design our operating room and perioperative areas for success? So let's start with the OR culture, or the operating room culture. A lot of the culture starts with the people and it starts with the beginning of the day. Here at Mass General, we do a general overview of every surgical day in the operating room. We discuss how many cases are planned, if we have any pending cases or waitlist cases, and we discuss surgeon availability, anesthesiologist availability, and nursing availability. And to frame this conversation, we are a tertiary medical center. In our operating rooms, we have about 62 operating rooms. Some of them are day surgery focused, but a lot of our operating rooms are inpatient, emergency, and ICU focused operating rooms. And so a lot of the discussion today will be focused on that, which may be a little bit different from an outpatient surgery center where it's a normal business operation between 8 a.m. and 5 p.m. We are much more of a 24/7 operation. At the beginning of our day, we sometimes huddle in person. We have a specific workroom. In this situation, discussing the cardiac surgical and cardiothoracic surgical service, we have an actual workroom that we physically meet all the role groups. So anesthesia, surgery, nursing, perfusion. We all meet to start and talk about how our day is going to look like. We also use virtual tools to help us. So we use our electronic medical record system. In the States, it's Epic. They're very similar programs across the world, but we use Epic. And that really helps us sort of plan our day and really have a bird's eye view of how many cases we have for the day, who's doing those cases, and what needs to get done before everyone can go home today. Everyone that works in healthcare is there for the patient. But we also have to remember that everyone has lives outside of healthcare and outside of patient care. And so we want to be respectful of that. And I think starting the day off on the right foot, discussing what our expectations are. And I think a lot of unhappiness with personnel and staffing comes when expectations are not met or we fall short of those expectations. So a lot of what we do at the beginning of the day is setting those expectations. Who are the key personnel? So more important than physical resources are the human resources. And we really harp on this here at Mass General because I think that there's nothing more important than the human resources that we have in the operating room to make it a very efficient operating room, operating theater. We have our lead surgeon for the day. We have an anesthesiologist for the day, a lead nurse manager, and a lead perfusionist. And again, this is specific for cardiac surgery, but systems like this exist in all surgical services, whether it's GYN, neurosurgery, orthopedic surgery, urology. We have this sort of layered group teamwork in all of those surgical services. The reason why we have this is that it identifies one key person, one sort of captain for the day. This person is able to manage all the resources and also help us get through the day efficiently. It's nice to have one person that you know that you can go to. For example, if you're having an issue with a nurse on that particular day, or there's an issue with turning over one of the rooms, we know who the lead nurse manager is, and we can go to that person and we can say, hey, how can we help? How is it that we can help this nurse, for example, help turn the day over or keep things moving a little bit smoothly? Aside from personnel or staff, we also have our equipment, and equipment is really important. And I'm talking about sort of the day-to-day reusable surgical equipment. One of the things that we've established are prearranged case carts. And these are predetermined needs so that we're not surprised every day with every case what surgeon X may want to perform an aortic valve replacement. We want to make sure that we have the same equipment every time, every day. And that really helps us keep things moving and keep things very smooth in the operating room. Now, this does take some upfront work. We had to sit down with all of our surgeons and go through a majority of their cases. Now, we're not going to get every single case, but a majority of the work that they do. And we go through and say, what are the pieces of equipment that you need to perform this surgery? And so all of these case carts that come from our central sterile processing department are specific to the case and specific to the surgeon. And so it's really important for us to emphasize proper case booking, proper and accurate case nomenclature so that we know which case cart to get for the surgeon and for the case. As mentioned previously, one of our main goals is to meet the expectations of our staff so that everyone works diligently throughout the day and can go home to their families. And I think one of the key points here is if you want to end on time, if you want to end the day on time, you need to start the day on time. And so we have a set of certain expectations as to what that means. For example, for our cardiac surgical patients, we want to ensure a consistent patient arrival to the institution at 5:15 in the morning. We want to clearly communicate the expectation of the patient arrival in the preoperative holding area. And this at 6:30 a.m., this is the first interaction that the patient has with our perioperative team, the anesthesiologist and the surgeon. At 7 a.m., we expect that the patient will arrive in the operating room, ready for induction, ready for central line, arterial line, whatever the patient may need for that particular surgery. But we expect at 7 a.m. that the patient will be in the operating room. And then at 8 a.m., we expect incision time, no matter the procedure. And so by 8 a.m., the patient has been anesthetized, the patient has an arterial line, a central line. The patient's been prepped and draped and ready to make incision at 8 a.m. And as we set these expectations, it really holds everybody accountable to meeting these benchmarks, to meeting these times. So hinted a little bit about data-driven analytics, and I really want to dive into that here in this next section about what are the data sources that we use and what are the data reports, more importantly, because the frontline staff really cares about the data reports, whether that's daily reports, monthly, or quarterly reports. So we'll start first with a monthly report. So FCOT stands for First Case On Time Start. So I'm going to pick on the cardiac surgical service here just as an example as we move through some of these reports. But this is an example of a monthly report that we send out to the entire cardiac surgical team, not just the surgeons, because we know the surgeon alone is not the only indicator. He or she is not the only force driving the first case on time start, but the whole service as an entity is what's responsible for making sure that we start on time. And so we can see here for this particular month, we had an 89% on time start, which is really good. Our goal is above 85%. And we also have grace periods. So we'll have sometimes 5-minute grace periods or 10-minute grace periods, because we know when we're working in healthcare, patients are not widgets and not every patient is the same. And so we understand that there needs to be a little bit of a grace period there. So 89% was very good for this service. So we share this on a monthly basis so that we can track it and we can all speak to the same set of data. Another monthly report are turnover times. We think that not only starting on time, but the time in between cases is important as well. And we don't want to waste time in between cases, because when you don't have a case in the operating room, not only are you not caring for patients, but you're wasting time, money, and valuable resources. So again, as an example for cardiac surgery, in this particular month, cardiac surgery had an average turnover time of 61 minutes, which is pretty good for cardiac surgery. Our goal is around 60 minutes, plus or minus 5 minutes, having that 5-minute grace period. So 61 minutes is very good. We have to remember that for this particular service in cardiac surgery, a lot of the patients post-operatively are going to an ICU, or even pre-operatively maybe coming from an ICU for a return to the operating room. And so 60 minutes is a reasonable time. But at your institution and for your service, I think setting that average turnover time minutes, letting that be known to everybody involved and tracking that. For example, our gynecology and orthopedic services, we have a goal of 45 minutes because we know there isn't as much equipment to open up. There isn't as much patient prep that needs to go into those type of surgeries. And so our goal for that is 45 minutes. So those are monthly reports. It's very almost 30,000 foot view of what's going on in the service. But we also think it's important to zoom in a little bit and to really focus on providers themselves. So we actually have data for each type of provider in the operating room. So for example, our anesthesiologists, we have a provider dashboard. We utilize Tableau. And on this provider dashboard for anesthesiologists, we're tracking the average time from the patient being in the room to what we term as induction complete. And so that's everything related to the patient, from bringing them in the room, getting them on the operating room table, placing an IV, an arterial line, a central line, intubation, whatever needs to be done from the anesthesiologist point of view, from in-room to induction complete. The target time for that is 50 minutes. We also have surgeon level provider dashboards. For the surgeon, either the surgical team, the fellow, the resident, the trainee, what we care about for them is the time from when induction is complete, meaning the anesthesiologist is handing care of the patient over to the surgeon, from induction complete until incision time, until the surgery actually starts with the incision time. And so we track this as well. And our target here is 20 minutes. And so we can look at each individual surgeon. We can look at each day of the week. And this is something that we can report back to our surgeons to say, hey, over the last couple of months, we've noticed that we're starting to increase our time. Is there something fundamental that's occurring that's preventing us from being a little bit more efficient in the operating room? And lastly, we have the cumulative efforts, the cumulative work of anesthesiologist, of surgeon, of operating room and circulating nurse. And that's from in-room to incision time, essentially from when the patient enters the room to when the scalpel hits the chest. How long is that taking us? And our goal is 70 minutes. And so we're looking for how do we make sure that we can have an efficient operating room with every member of the team. Let's discuss a little bit about our daily outcome dashboard. Again, this is cardiac surgery specific, and it's a more visual approach to the data in the previous slide. And so we're looking here specific to day of the week and specific to the operating room itself. And so we can tell if certain operating rooms for example, on Mondays, are a lot slower than that same operating room on Wednesdays or Fridays. We can see that here, and we can sort of figure out what are the impediments that are occurring on a Monday, and why are we slower on Monday? Is it because we've all starting our week on Monday, or is it because there's something physically entrenched in that system that's causing us to be delayed on Monday? And so we have these on Tableau, and we have these available to all surgical and perioperative staff to view. Moving on to a little bit of a different type of data, we're going to discuss case volume reports. I think this is very important because the operating room, as mentioned, is a very valuable resource in any hospital and any healthcare system. It's very valuable, it's very expensive. And so we want to make sure when our surgical services and our surgical team is budgeting for how many cases we plan to do in a period of time or in a fiscal year, that we're tracking that we're holding ourselves accountable to that. It also helps us understand whether we need a budget for more time, for more OR space for a particular service. So we're always comparing the actual case volume versus the budgeted case volume. We do this over a month, over a quarter, and then over a fiscal year. And we actually review all of these reports with our chiefs of surgical service. So every fiscal year, at the end of every fiscal year, we review this data with the cardiac surgical chief, and we discuss, did we meet our budget? Were we above our budget or under our budget? And how will that affect our allocation of this precious resource for the next fiscal year? Next is a very hot topic is the utilization report of the actual operating room time on a given day. And so we have a lot of metrics here, so we'll walk through some of them. The first is our prime time allocation, or what we call prime time is 7 a.m. to 5 p.m. And you can really decide at your institution what that looks like. If you're at an outpatient surgical center, maybe that's 8 a.m. to 3 p.m. If you're more like us, a tertiary medical center, 7 a.m. to 5 p.m. is generally standard. So we're going to look here at what is the percentage of block utilization. When we give a service a particular block of time, how much of that block of time are they actually using? And in this particular case, we have a 75% block utilization, which is pretty good. And then we look at what is the percentage of prime time utilization. And that's 76%. So that's very good. And we're really, for cardiac surgery, as we know, there's a body of work that's being done outside of business hours, emergent cases, urgent cases. We also, at our institution, get a lot of referrals from outside hospitals. And so we understand that not all the work is going to be completed between 7 a.m. and 5 p.m. And that's why we have this last column, which is non-prime time hours used. And so all of these data points are very important to help share with everyone in the operating room so that we're all level set, we're all on the same page and understand what our utilization is. Are we being efficient with our utilization, with our block time, and making sure that, hey, maybe we need to give more time to a particular service, or the opposite. If a service has poor utilization, we can say, you know what, we need to scale back or reduce the amount of block time utilization that a particular service may have. Moving on, I wanted to discuss efficiency improvements. So we talked about the OR culture, we talked about the data-driven analytics. So now the question may come, well, what do we do if we have a particular service that may be underperforming? You know, we've presented the data to them, we've tried to foster a culture in the OR, but we're just not hitting the mark. We're not meeting our goals. How do we improve that? And so the next few slides, I'm going to give you a case example of exactly that we did here at our institution, of an efficiency improvement within the operating room. Just like in other industries, we need to use certain principles to help guide our work. And so utilizing Lean or Six Sigma, these are two very powerful tools that help us guide this type of work. So Lean, that's the approach that seeks to improve flow in the value stream, which in this case is the patient journey, to identify and eliminate waste. It's not just about telling the team, hey, we need to work faster, we need to work harder. We don't want them cutting corners. We want to really make sure that we're eliminating waste or redundancy. So as most of us know, the Six Sigma, we're going to define our reason for action. We're going to measure both the quantitative, which is the turnover time, and the qualitative, which is staff and patient satisfaction. Because it's not very helpful to reduce your turnover times, increase your efficiency, but have a bunch of staff that are unhappy, burnt out, and wanting to move on from your institution, because then you're having to start over fresh with new staff. And so we really want to make sure that our staff and patient experience is top notch. We want to analyze. And so part of our analysis was understanding the current state of data. In this particular case, we were focusing on the gynecology surgical patients. We want to improve. So we want recommendations for process change. And we don't do that at the first meeting. You know, we had 7 or 8 different meetings, hour-long meetings, sometimes 2-hour-long meetings. We didn't dive right into ideas on the first meeting. We wanted to really set the groundwork first. And then on our second or third meeting, then we started talking about solutions. And then lastly, when we got into our maintenance phase, we review and reevaluate success for this process change. One of the things that we did was initially map out our process. So when we wanted to improve our OR turnover process, and I say that this is for our turnover process. If your metric was first case on time starts that you wanted to improve, then you would have to do a very similar process for nuts to bolts. How are we getting our patients into the operating room? But since our focus for this was OR turnover process, we did a nuts to bolts for every role group in the turnover process. And so I know that the font is kind of small here, but this is just to serve as an example of how in-depth we went. We went through every single role group, from surgeon to technician to nurse to anesthesiologist. What exactly are they doing between the first patient leaving the room and the second patient entering the room? And the yellow star was identified as areas of waste or redundancy, areas that we can identify and focus on and hopefully eliminate. Another, aside from a swim lane, another way to do this is a process map, where we really walk through what are the critical and non-critical parts of the turnover and of the operation, and where can we sort of trim the fat, so to speak? Where can we focus on, rather than just saying, well, the entire process is slow and I'm not sure how it's slow or why it's slow, but we just need to make it faster. You need to dissect and be searchable about what areas you want to improve. For us, we were focusing on the component of the OR turnover for the next operation. And as we can see here with the green and the blue arrow, that was the area that we were focused on. We weren't focusing on the actual operation itself, telling the surgeon to operate faster or slower or whatever it may be. That's not the point. The point was to reduce and eliminate waste. And that's why this type of process map is very important in that. So I wanted to wrap up with discussing designing for success. And so this is really a key part of what we want to do for the future. When we were looking at our swim lanes of OR turnover, for example, and where there were inefficiencies, we noticed that one of the key points that kept being raised was geography. Well, I have to walk from the operating room to the preoperative area where the patient is, and then I have to take the patient to the PACU or the recovery bay and check on my patient from the previous case. And just the distances that were having to be walked were really far. Additionally, for example, if a patient needed an IV or an arterial line, well, when I went to go see the patient in the preoperative area, the equipment for all of that was in a completely different location because there was no storage equipment near the area of the preoperative holding bays. And so our anesthesiologist or nurse would have to go see the patient and then walk all the way to the equipment room to gather the equipment. And so we felt like that was really redundant, that was really wasteful. And we wished that we could really co-locate all of the resources, the patients, the equipment, and the nurses and the anesthesiologists in the same space. So we took that lesson, and as we are preparing here for the opening of our heart and vascular tower, as well as our cancer tower, we're actively building 2 new towers here in our Boston campus in Massachusetts. We really wanted to make sure that the procedural area was really laid out and designed thoughtfully. And so this is an example of a working architectural diagram that we are working off of for how we're going to co-locate our peri-procedural bays or perioperative bays, as well as the ORs and procedure rooms. And so we can see everything is here on the same floor and everything is co-located, meaning all of the operating rooms and all operating theaters are co-located together so that we can put all of the equipment, all of the clean core, all of the necessary equipment that we need and resources that we need together close to the operating room so that we're not having to walk long distances or go to a different floor for that equipment. It's all there right next to the operating room. We also have at the top of this map, the peri-procedural bays in purple. All of the peri-procedural bays are next to each other. So that way, again, you only have one stop. You only have to go to one location to find your patients, to see your patients, and perform any peri-op, either pre-op or post-op care for that patient. In the center of this layout is our elevators, is our staff area, and our blood bank. So everything is sort of the feng shui of the flow of the patients, of the staff, needs to be thoughtfully designed when you're designing a new operating room. There's not much that we could do with our older building. We built some of our buildings are 200 years old. We can't necessarily change that. But what we can do is when we're building new locations, really think about what were the roadblocks for success? What were the roadblocks for efficiency that we can overcome when we're building a new location? And that's the end of my presentation. And I think we'll have a Q&A session at the end of the other presentations. Thank you so much.
Adam, thank you so much. That was super interesting. And I found it really interesting how you brought together the various aspects of the human dimension, the comms, the process, re-engineering, if you want to talk about that, or redesign, the analytics. I know there's always a lot of interest in that in our organization. And last but not least, the design. I think every single person on this webinar will be nodding their head at that. But the other thing that really struck me listening to you is how so many of the issues that you're describing there at MassGen, how they resonate with us in Kenya and Uganda in such a totally different, resource environment, epidemiological environment, and so on. But you could be talking directly to people there. So thanks very much. Adam, there are already a whole bunch of questions coming through to you if you look at the Q&A icon there. So maybe you could type out a few answers to people, but if we have time, we'll come back on some of those to you as well.
Yeah.
So thanks so much, Adam, for that. So
Thank
yeah,
you.
moving on and moving just down the road actually in London, to Candisic. Candisic, for those who don't know, is a very well known UK-based healthcare consultancy, very well regarded. The corporate mission of Candisic is to improve care outcomes and drive better and longer lives, combining strategy with deep sector expertise. We have Jack and we have Michelle. Jack Zane is a senior engagement manager with a track record in strategic consulting and transaction work. He's worked on more than 50 projects across medtech, health tech, healthcare, as well as adult social care and children's education. Before Candisic, Jack was a consultant at LEK, which is also very well known here in the UK. He brings experience from Australia, Boston, and Singapore, as well as Britain. Holds a commerce degree with distinction and a law degree from University of New South Wales in Australia. He is accompanied by Michelle Tempest, Dr. Michelle Tempest, who is senior partner. Michelle is a medical doctor with 14 years experience working at the front line in the NHS in community and psychiatry. She spent 3 years advising NHS England. She's previously advised the government here in the UK on health policy and edited the book, The Future of the NHS. She continues to work with Lord Pryor, working on healthcare variation. Outside of Candisic, Michelle lectures at Cambridge University in medical law and ethics, and she has a medical degree from Cambridge University and was awarded a commendation for legal matters. So Michelle and Jack, very impressive credentials, very different experience, I'm sure. Look forward to hearing from you. So over to you.
Thank you. And thank you for Dr. Adam before. So again, I'm going to attempt the very dangerous thing of trying to get the slides on the share. Is that all up?
Yeah, got it. Can see it perfectly. Thank you. Thanks.
Fantastic. So I'm going to skip past that, given we've already had an introduction. But just a reminder, I'm Jack, and this is Dr. Michelle next to me. And what we're going to talk about is we already talked about the efficiency around sort of operating the OR. What we thought would be really useful was to talk about some of the things around the operating theatres that can go wrong, which will cause you to actually lose a whole operation or cause you to, in some of Dr. Adams' later work, part, talk about how you end up with patients in the OR and increasing the turnover time. So we work with a lot of private clients who face these problems every day, but I've also brought in a lot of NHS data, which illustrates the exact same point in terms of what are some of the problems. So if we start, before you even get to the operating theatre, there are a lot of things that can get in the way of you actually getting the patient in the theatre. The patient simply can choose not to turn up on the day without telling you. There might be some issue and you have to cancel their operation, or they didn't follow your preoperative instructions, which means they turn up not ready for an operation, or they arrive late, which means that if you're tracking your first start time and that's your first patient, everything's just moved back. But even after they arrive at the hospital, now we have another set of potential things that could be a problem. So when you call for the patient, they might not have had enough time to be fully prepared for the surgery. One thing actually in the UK that happens a lot is there is no porter available to transport the patient. And unfortunately here, you must have a porter to move the patient to the theatre. And so that can cause delay. Or sometimes someone hasn't arrived on a shift, a replacement hasn't been able to be found, and actually the whole theatre team can't do anything until a replacement member is found. And then the last one is potentially there is downtime in between because you haven't called for the patient early enough as you go through the turnover process. At the end of the pathway, there are also other things that can happen from operations point of view that has nothing to do with the surgical team. So maybe certain post-operative procedures can't be done because of a lack of room or because someone hasn't moved out of the area yet. Maybe you haven't got turnover sorted out as well. So you actually have a delay in sending for the patient, which means that you're spending time on the next patient waiting for them to turn up. Or because you had no porter, you're missing a porter at the start, there's still no porter to move the patient out of your operating room. So again, you're waiting for someone to turn up. Or the inpatient bed that the patient was planned to be in has not freed up because you're running quite hot in terms of bed availability. So these are all some of the things we've seen that can, outside of the surgical team's control, affect your surgical efficiency and affect the amount of time you get to use your operating theatres for. So if we have a look on the first point, which is sort of patients not turning up or cancellations, if we have a look at since 21-22 Q3, the NHS themselves have cancelled about 250 elective surgeries for non-clinical reasons. So these are just the ones where it's either bed's not available, surgeon's not available, etc., which is about 1% of operations. But actually, when we have a look at other reports that look much more deeply into cancellations, so we found a 2018 study that looked at 245 NHS hospitals over 7 days, and they found that 10% of the patients who turned up had a previous cancellation. And what are some of the reasons? You have your clinical reasons, which is about a third, but then you have a lot of other operational reasons around the hospital: lack of beds, insufficient operating theatre capacity, and various other reasons. To back that up, there's also a separate study which took a longitudinal amount of data from a hospital in the UK. Now, this hospital is specially built for what we call elective procedures. So it doesn't do emergencies. It's purely focused on doing things like hip replacements, knee replacements, and other surgeries like that. And when they did that study, they identified a lot of different reasons as to why a surgery got cancelled. And what I've done here is highlighted in the darker colors the kind of reasons that can be avoided, with the intention of us getting more awareness of where are the places. So patients not attending or patients cancelling is a major factor. The operation not being necessary. Sometimes it's actually, again, a result of not having enough patient contact before the surgery. And then you have other things like staffing issues, booking errors, etc. So what I want to focus on the next page is talking about the patient reasons for not turning up, because actually in the UK, it's a really big problem for us when patients don't turn up. We've scheduled time, things are prepared, but if they're not there or they're not ready, you lose a whole chunk of time that you can't recover because you can't just call a patient to turn up to fill that slot. So what we've learned is actually on the left-hand side, you need to be able to use tools to help you engage with the patients so that you can plan and automate your communication. So it's not someone's job to remember to follow up with every patient before the day before their surgery. There is a lot of value in validating your waiting list of patients and making sure that there are not people who no longer need to be treated because either they've gone somewhere else or they've had a different doctor treat them that they didn't think to tell you about. There's also tools around really useful AI tools now that you can identify the risk of people not attending. So leveraging those, you have the possibility of identifying the ones that you really need to reach out to with a lot more effort. And also we found that giving patient access to appointment management is really useful in terms of making sure that they have an easy pathway to communicating with you if they can't turn up or there are issues. From personal experience, having used the NHS, sometimes it's very hard to get in contact with the hospital to tell them you have circumstances, which means you need to move an appointment. So that is really useful. And then finally, digital forms and assessments that allow clinicians to get the information they need before operations, we've found to be very valuable because now you're able to get the patient to, in their own time, actually give you all the key information you need, which if we look back at the slide before, on the right-hand side near the bottom, unavailable inadequate investigations, medical notes not available, some of that can be reduced if the patient actually provides you the information that they have that you do not necessarily have. On the right are some examples of companies that operate in the UK, which have really useful digital engagement tools that have been used across the NHS. And this, yes, Dr. Adams also talked about this, but data tracking is invaluable in thinking about how to start understanding where your efficiency gains can be. So on the left-hand side, we've set out the various steps of tracking that you could track. There are also things within that that you can start tracking, and Dr. Adams' system at MassGen, has a lot more detail in what happens after a patient arrives at the theatre. But using these, we can start thinking about what investigations you can do to make sure that you're really optimizing all of what's happening before and after the patient enters the theatre. So for example, if you have really good tracking at the front end, then you can start thinking about, are we sending for patients fast enough? And start identifying any issues or bottlenecks in patient movement. And then you can start asking questions like, is it because there's no one there to move the patient? So if we start moving to the right-hand side, is there no staff available to see that request? Or is there no one that is available to move them? Or is there an issue with the physical environment around you that causes a patient to be moved very slowly? For example, is there a certain day where something in the hospital happens and you have to go around that because there are a lot of people in that area at the time? And that helps you really start asking the questions to help you get to a point where you can minimize the amount of time it takes for a patient to get to the theatre to where it really should be based on your hospital. And on the post side, it's about how you can start asking questions about, do we need certain areas to move people to so that they don't impact the turnover? Is there anything we need to do? Or do we actually have to work on making sure that inpatient beds are available when they are needed? And that can be an area of focus too. So with the data, you can go a long way in terms of understanding that. And when we've worked with our independent hospital clients, getting this data that they track has been really useful in helping them work out where there are other efficiencies that they can gain. Finally, moving over to the end of the pathway, one thing that we've noticed is that if you do require inpatient stays, you actually really want to minimize that stay so you can leverage your hospital beds. And some hospitals, it's not actually the theatres that's a problem that's restraining them, it's the amount of beds they have. And yes, you can build more, but that costs money, it's expensive. And one thing that the NHS has done over time is actually looked at in orthopedics, getting better outcomes, which I'll show you on the next slide. But what I want to show is that there is a very big divergence between different providers in terms of how long their replacements are, how long patients have to stay as an inpatient after a hip replacement, for example, and then how much turnover time. So there are opportunities across all of these areas. And you'll see in the middle that the NHS average is actually very high. And part of that is because they typically take sicker and more complex patients. In the UK, our private or independent hospitals are built much like the example before, where they are only doing elective surgeries and therefore don't do emergencies and don't have that kind of disruption. But regardless of which way you go, what the NHS has found for its Get It Right First Time program is actually that you get better outcomes if a surgeon does more surgeries. And therefore, what they're focused on is trying to get minimum amounts of surgeries which are performed. What they found is as they have progressed this program to get surgeons to do more volumes per year, they've been able to reduce the average length of stay, increase the use of bed case surgeries, day case surgeries, sorry, and reduce the amount of revisions, which actually cause unnecessary activity for you because now your one patient is coming back into your OR again when you could be treating a new patient. And finally, Michelle has a very interesting company that actually is very related to this in terms of their ability to leverage data to get real world results. And I'll let her share a bit.
Yeah, so I just wanted to add a couple of things. So thanks for that, Jack, very helpful. And the first thing I wanted to add was surgery everywhere is a multidisciplinary team. So that includes not just the human team, but as we sort of said, the whole system has to run as a team as well. And so often measuring the whole process and pathway is really key to understand where you can get efficiencies. And the other thing which I wanted to mention is how surgery is becoming very globalized. And we actually work with a company named Care Syntax, who some of you may know. And what they've managed to do is really think about it on a global scale. And when you have new devices which come to market, they actually go all around the world, often in research centres and hospitals around the world, and actually ask individual surgeons around the world to try out the new bit of kit and then send back the evidence and then publish it. So I think there's real excitement, exciting times, and not just looking at kind of the way that we are operationally improving things in a similar way around the world, but also the way that we're looking at sort of new surgery research and development around the world. So I shall hand back over. Thank you.
Thanks very much, Jack and Michelle. That was really interesting. And I must say, for me personally, I guess there were two things that really resonated. The first is the nightmares were coming back. My first job was NHS management at Hammersmith Hospital in West London. Young 20-something-year-old. My job was reorganizing cancelled outpatient and operating lists. And it just struck me just how much is lost for reasons that are nothing to do with money. So very, very interesting to get your insights on that. The other thing that resonated, and I think this is a feature of many emerging markets, was your comment about minimum volumes. In many markets, this is an issue with surgeons not just not getting enough practice. And I used to manage a company in Russia, and I know there are some people on this webinar from the former Soviet Union, but because the system trained so many doctors we always had this issue with, you know, low case loads and just not getting the expertise. So thank you very much for that. And I can think of some questions myself that we may come back to. And by the way, if you guys, Adam, can address any in the Q&A directly, that will be great. Before I move to Uzair, just to say that I can see that we have more than 500 participants in this session, which is a big number for us. There's a lot of interest from all over the world. I see a very strong representation from Africa. So that there's a lot of interest in this session. So Uzair, definitely last but definitely not least. So Uzair is based in Lahore, Pakistan, and he is Chief Operating Officer of the Evercare Hospital Lahore, which, for those who don't know, is a leading hospital in Pakistan, very well known, very well regarded. So Uzair, as I said, is COO. He oversees the operation of the hospital across operational excellence, patient experience, financial management, quality, all aspects of the business. I think it's fair to say that Uzair is regarded in Pakistan as, you know, one of the visionary leaders in the sector. Among many achievements is the development of an in-house hospital information system aimed at improving efficiency across all operations of the hospital. And that actually won the Technology of the Year award in Singapore in 2023. I could mention other achievements relating to expansion of cancer services, quality improvement initiatives, but maybe just to sum up by saying, you know, Uzair's philosophy is to foster a culture of accountability and empowerment within his teams, ensuring respect, delegation, and consistent appreciation of progress. His work resonates with a global audience, and Uzair has not only worked in Pakistan, but also collaborates with the Evercare Hospital in Lagos, Nigeria. So Uzair, a lot of challenges. You're doing a lot of good work over in Pakistan. Really look forward to hearing from you. Thank you.
Okay, so thanks, Amit. Thanks for the introduction. I was just wondering who are you talking about, but thanks for the humble introduction. So I'll start with the most difficult part, as you mentioned, sharing my screen. Okay, so I believe my screen is visible.
Yes, perfect, Uzair. Thank you.
Okay, so good morning, good afternoon, everyone, and thank you for being here today. As we walk through this presentation, I really want you to think about a journey where challenges are met with innovation, teamwork, and of course, data. My name is Uzair Sheikh, and I'm working as Chief Operating Officer at Evercare Hospital Lahore. And today, I'll walk through you how we transformed our ORs from, I'll use the word chaos to efficiency, from manual systems to data-driven decisions, and most importantly, how we achieved measurable improvements that speak volumes. But before I move on to the presentation, I'll just quickly brief about the Evercare Group. So Evercare Group is a leading healthcare provider committed to delivering exceptional patient care and advancing healthcare services across the emerging markets. That includes a very strong presence in Pakistan, Nigeria, Kenya, and a head office in the UAE as well. So Evercare operates a network of state-of-the-art hospital, medical centers, and wellness facilities. So we currently are working in 3 countries. We have 5 hospitals, more than 25 medical centers now, and more than 500,000 care providers. This is what the hospital values are. We specialize in critical care, we HDUs, ICUs, state-of-the-art operating rooms, and the acuity of patients that we get at Evercare Hospital Lahore is generally very high if we compare to the other hospitals working in the city. So let me start by setting the scene here. In 2022, Evercare Hospital Lahore opened its doors, but like any new venture, we faced a fair share of challenges, from manual scheduling to communication breakdowns. Our operating rooms were struggling, and patient safety and their experience and even staff morale was suffering. But as they say, from challenges we build opportunities. So when we begin evaluating our operating rooms in the Q4 of 2022, to be very specific, we found ourselves dealing with several critical issues. Number one, manual OR scheduling. That includes manual processes for patient booking and scheduling. Lack of KPIs to track critical metrics like start times, changeover times, infection control, OR utilization, and some other clinical KPIs that I will talk about in my upcoming slides as well. Communication gap between doctors, nurses, and especially the administration. Also, over dependence on hard copy medical records, slowing down the flow of information, and inaccurate billing that leading to confusion in charges to medical supplies and procedures. And all of this wasn't a minor inconvenience. It really had a very real big impact. Patient safety was at risk, operational safe efficiency was low, and ultimately our hospital's reputation was being jeopardized. But here's the good news. Instead of shying away from these challenges, we faced them, at least we tried to face them head on. So moving on to the turning point, we call it reimagining the operating room. We kicked off what I would like to call I would say, operating room revolution. So now here's where the story gets real interesting. What we did wasn't about implementing a new system. It was about changing the way we think, the way we work, and most importantly, and the most difficult, the way we collaborate. Our first step was implementing the in-house HIM system, a health information management system, designated to integrate with our ERP system, which we thought would be a very difficult task to develop and to implement. But later we found out implementing technology is the easier part. And what's the difficult part is something that I'll talk about later. So this wasn't just a tech upgrade, it was a complete cultural shift. We linked patient scheduling across OPD, IPD, and the ER, enabling smooth patient journeys. We also moved from paper-based medical record to digital documentation, ensuring compliance with some of the best standards in the world, to be specific, the Joint Commission International. So we made KPIs visible in real time. We started tracking everything from OR utilization to OR changeover times to the surgical checklist. It was like, I'll say that, imagine trying to make improvement without data, because the system was just being implemented. So we did not have historical data. It was like trying to fix a leaky roof without knowing where the leak is. But it was just not about technology. We need a cultural transformation as well. So what we did is that we created the operating room committee, which has representation from the surgeons, the allied staff, nursing, CSSD staff, and I'll say the most important people, the administration. The purpose was to meet on a monthly basis to evaluate performance and share feedback, and any small improvement was also to be discussed in that forum. We broke down silos, fostering collaboration between doctors, nursing, and collaboration and administration. So we made sure that everyone has a seat on the table, and together we address the challenges. You see, the purpose was that we just didn't want to install a software. We wanted to build ownership and, most importantly, trust between the care providers. So these are some of the snapshots of the HIM system that we in-house developed. So on the top left box with the blue border is how we were capturing OR utilization. You can see the utilization for August 2024 for 43%. In the left down box with the green border is where we had OR appointments OR wise, and on the right picture is the details of the OR. apart from that, these are all general management administration ORs, but not only that, we were also monitoring site marking through system, search swab counts, timeouts, surgical site information, surgical safety checklists. So all this data, which previously we did not had, was now not only coming on a real basis, but now coming through the system. So every single data was now available to us on one click. So what were the outcomes? The results were that they speak for themselves. We didn't just improve. I would use the word we excelled. Here's what we achieved. A 69% growth in OR volumes by Q3 2024. So 1 year down the line, there was a 69% increase in volumes, 100% reduction in surgical site infections and post-operative mortalities, and less than 5 OR incidents that happened during that period. So you see, these aren't just numbers. You can see, you can refer the graphs as well, that the OR volumes are increasing and the surgical site infection and the post mortalities are on the downside. So these are actual real volumes. So these are just not just numbers, as I mentioned in my slide as well, that these are improved lives, these are surgeries performed, and this is safety enhanced. It was a powerful testament to what happens when technology means teamwork and data-driven decisions. So the lessons learned, change management has to be inclusive. It cannot come from one way. It has to be done from day one. The stakeholders need to be involved when you're implementing either a small thing or a big project like this, because you don't want to show that you're imposing something. You want to empower everyone. That is something which usually administrations are not good at. Cultural trumps tools. Sure, we can have the best technology, but collaboration is what I call the secret sauces. Another important thing is that data drives trust, and soft skills really matter and are as important as a technical skill. If you're able to communicate effectively with others, I think half the problem is solved right there. So the next steps, I'll say that when we implemented this project in Lahore, we didn't stop at Lahore. Why limit ourselves when the success was clear? And as you can see in the slide, that our motto was that from one hospital to a movement. And by March 2024, we expanded the initiatives to Evercare Hospital, Nigeria as well. The key scaling project, the key scaling to this project was cross-learning between the teams. Our surgeons from Lahore trained the Lekki, Nigeria team. We shared our best practices in specialties like bariatric surgery, neurosurgery, and urology. What's exciting is that Lekki's initial results are also showing an upward trend in patient volumes, although the data is still very limited, but we are seeing positive signs. And I would like to mention one thing is that quality is only scalable when the culture and systems align. And in our case, in both the hospitals, the cultures and systems were aligning, and that is why we felt that the quality can definitely be scalable. So what we really focused on is the training of the OR staff, the awareness session of the OR staff. So you can see there's a continuous process of training these healthcare providers regarding infection control practices, how to implement the timeout, how to make sure the swab counts are being correctly, the clinical documentation that is being done pre, post, and intra procedures. So these are a continuous reinforcement that we done on a monthly basis. These are some of the pictures that you can see, that the collaboration between the Nigeria team and the Lahore team, and you can see the center picture in the OR, that is a Lahore surgeon, a Pakistani surgeon doing a bariatric surgery with the Nigerian, our surgeon in Nigeria. So this was the first bariatric surgery that was done in Lagos, Nigeria hospital. Because you see, the better OR performance isn't about just working harder, it's about working smarter and working together. Thank you.
Thanks so much, Uzair. And it's really interesting to see, how you actually delivered improvements there and to see the scale of those. You're there on the ground in a low, in a much lower income environment, let's say, with a lot of challenges that we don't have in the UK or the US. So it's very interesting to see a little bit similar to Dr. Adam, I think, how you use the change management and the redesign to deliver improvements. So I have a few questions actually, and I'm trying to draw from the list of questions we have as well. And Uzair, actually, maybe I'll just start with you as it's freshest. But we're seeing an increased internationalization of healthcare, where companies are going across borders, like Evercare. Now, in private, many healthcare leaders have, complained about how difficult it is to transfer practices across borders. What were the differences that you saw in the challenges in Nigeria versus Pakistan? And what was different in your approach there compared with in Lahore?
That's a very good question. Amit, you see, the first statement that we used to hear is that this is not happening in Nigeria. This is not Pakistan. So whatever you want to implement, this was the first resistance that we used to face. But I think the project that was happening in Lahore, we were doing it for almost 2.5 years. So the teams were very trained, and not only we knew what to do, we also know what not to do. So the most important thing that when we went to Nigeria, is that immediately got the buy-in from all the stakeholders. Like in our case, we implemented OR committee 6 months after the project, but in Nigeria, the OR committee was the first thing what we do. What happened is that all the stakeholders were sitting on that table, including the surgeons, the nurses, the sterilization people, the administration, and we told them that this is not our project. This is your project. You are the champions. You need to go on the ground, convince people, manage the resistance, improve the operation process, because the objective that we all have is to improve patient safety, improve patient satisfaction, and the downside of it is that the volumes will automatically improve. It took us a bit of time because people were working in silos. They were not sure whether the new system will be adaptable on the ground or not. But the good thing was that because those guys were champion, so we did not had a Pakistani team leading it. We had a good number of Nigerian team leading it as well. That helped us to manage the resistance and improve the culture.
Very interesting. Thanks very much, Uzair, for that. Adam, maybe I can come back to you. So, Adam, it's very interesting listening to you about how you bring the different parts and the different people together and the whole change management aspects. So, a lot of my career has been in hospital management, and my experience is put 10 surgeons in a room, you'll get at least 11 opinions on the best way to do things or not do things. How did you get people together to work together in this way to keep them on board to deliver a high performing operating department?
Yeah, no, that's a good point. I mean, I think the same could be said about a lot of individuals in healthcare. We're all very sort of type A personality folks. I think that the big thing was coming to the agreement that what our common goal was, what our shared goal was. And while we may have difference of opinion on how to get to that, writing that goal down, putting it up there on the board and saying, how can we as a team get to this shared goal? And we listened to all of the 11 different opinions, and we worked through which ones may work, which ones may not work. And I think that when other role groups are hearing from the surgeons and the surgeons are hearing from the other role groups what the challenges are and what other responsibilities they have to do for the day. For example, when we did this, We had our central sterile processing department there at the table. And a lot of the surgeons had never met anybody from the central sterilized processing department. They just knew that their sterile equipment showed up in the operating room and it showed up on the table. And they had no idea how it got there and what went into getting it there and what the challenges are on a day-to-day basis for those individuals. So I think that that's a big part of it. And the same with nursing and anesthesia. They did not know what the challenges were for the surgeon who has to not only operate, but potentially go talk to the patient's family before and after the surgery, maybe see patients in a clinic, and all the other various tasks that a surgeon may have to do. So I think knowledge sharing and just being open and transparent about what I have to accomplish in my day, but then bringing it back toward the common goal of on-time starts and turnover and reducing turnover times. And that really seemed to help.
Thanks, Adam. Yeah, so much of this is change management and the human aspect. It strikes me. Jack, because I'm based here in the UK, I have to ask you. So you've worked across the NHS, which for those who don't know is the UK's government-provided system, and the private sector. What differences did you see, in the challenges, but maybe more importantly, in driving operational performance between the two?
Yeah, firstly, the very big difference that we can first go to is the independent sector here doesn't do any emergency medicine, which means that all your planned surgeries are your planned surgeries. And, something might go wrong in a surgery and you might have to send a patient off to the NHS for emergency medicine, but you don't have that kind of distraction to suddenly take your whole list and throw it out the door. Which means that there is a lot more possibility of doing that. In the NHS, there are dedicated day case and dedicated elective surgery theatres, but they're few and far between. And often, when there is emergencies, you still need to use those resources to, help in that emergency situation. So it's a lot harder when you're a full-fledged hospital that has emergency to really get that efficiency when you don't have certainty of your list. In the independent sector, though, there is the other thing, which is it's hard to always be super efficient because the surgeons are the customer for an independent hospital. It's just the way that it's structured here. So you can't exactly tell a surgeon who wants a 4-hour block of time that, hey, you're only using 3, so I'm going to slip in 2 patients here to take up all the time. So the independent sector here does struggle a little bit because of the power dynamic between who is the customer and who is owning the patients.
Yeah, for sure. Yeah, and I guess the other thing is just that the NHS hospitals tend to be a lot bigger than
Massive.
hospitals. Yeah. Uzair, coming back to you. So, I'm based in the UK. I spend, 90% of my work is in developing countries. A lot of the time people say to me, "Oh yeah, Emmett, that's all very well. That works in London, but it won't work here." Whether it's Lagos or Nairobi or Delhi. I'm sure you hear this as well. How do you how do you tackle that kind of resistance? And what would you say is genuine resistance versus let's say myths?
So, Amit, this was a challenge that we also faced, and I think that's a very natural challenge wherever you want to go in different companies and different organizations. If you want to implement change, people usually resist, and they have different excuses of resisting change. What we did is that we kept the data in the front. So wherever we were going, whoever was saying that this will not happen, that cannot happen, we were showing them data. And also, we also give them real-time case examples as well. For example, in our operating rooms, there's a distribution center. I'll call it the satellite pharmacy, in which the consumers are issued in the OR from that small shop. Let's put it that way. In Nigeria, in Nigeria hospital, that's what was not the case. So consumers were coming out of the OR, taking more time. The staff had to There were lots of runners around. And when we told them that if you have a shop in the OR, that will really improve the efficiency of the OR, reduce delays, and you will also be able to manage emergencies in a much more better way. Initially, they said, no, this cannot happen. We don't have space. That is not how the hospital supply chain operations work. This is not happening in Nigeria. No other hospital in Nigeria is doing it, but we try to convince them, let us give try. We will start from starting by having a small kitty, a small cabinet, and then we'll see. If it works, then we expand. If it doesn't, then we will stop it. And we know what the results were. The surgeons were very happy that the reduction of delays, the staff were also doesn't have to go running out of the OR, in the OR, in the surgical supplies, consumables were improved. And we also found out that the wastage started to reduce as well. So these are some of the initial examples and data that we showed them, just try to convince them.
Thanks very much, Azhar. So the clock is running down, and I want to make sure that everybody gets out in the next few minutes, because I know other people have things to do. But maybe I'd just like to come back maybe and ask everybody, you know, if there was one thing, one change that they would recommend to you know, the 500 plus people on this webinar to think about, you know, tomorrow or next week regarding improving their operating performance, what would that one thing be? So maybe I'll go in order of the speakers. Adam, what would be the one lesson you would give, the one thing you would say?
I think data. I think having the data, high fidelity data, and tracking and showing and sharing that data is really helpful, because it's very different when you go to a surgical service and say, hey, I think you guys are slow. I think your turnover time is slow. I think your on-time starts are lagging behind. It's different than if you go and say, hey, here are your peers, and here's how you compare to everybody else in the same operating room area, under the same geographical constraints and same system constraints. And you are 20% slower, or you are 20% more likely to not be starting on time. So I would say data is the answer, because a lot of us, we're all science-based healthcare staff and folks. We want to see the data and the science behind it. So, and not in a punitive or embarrassing manner, but just in a collaborative and very much so like, let's get you up with your peers. Let's get us together and improve together.
Yeah. You know, I'm smiling because that resonates so much. When we started the benchmarking service, when we were asked, we were like, why do you want us to do this? And it was exactly what you're saying. We don't have the data. We don't know where to improve. So thank you, Adam. Jack, what's the one thing you would leave with?
Yeah, I think, you know, making sure that you're communicating well with your patients is a very big one. Look, the NHS likes to send a letter and hope you turn up on time. And there are a lot of ways to go about it, you know, just even a phone call to each patient the day before the surgery to make sure they know where they're going, they know what time they need to be there. All of these things are such small things that people tend to forget, make a big difference to that. So my key takeaway would be, you know, review what you're doing in terms of your patient communication and make sure it works.
Thanks, Jack. Uzar, what are your parting words?
Thanks, Amit. So I'll speak on behalf of the management or the administration of a hospital. See, a lot of the times we try to enforce things. We try to use punitive approach if nothing is going well, especially when dealing with doctors and the nursing staff. I think the key learning for us so far, and the key learning for me in healthcare so far is that administration is not policemen. They are there to facilitate the doctors, the nurses, and they should see you. When they see you, they should be smiling that, yeah, now we see you there, he will get the problem gets fixed, rather than they see us and they start, there's more problem that Uzair is bringing. So I think that perception for the management is also very important.
Thanks very much. So data, communication, and management perception. Yeah, good ways to finish. So look, I can see in the chat and the questions, we could go on for quite a long time. We've had fantastic feedback. I see I'd like to say thank you to Adam, Jack, Michelle, and Uzair for a fantastic session. I've certainly learned a lot. A few things just before we finish. Please, everybody who's participating, do the survey on exit. This is how we learn as IFC. This is how we tailor our sessions. This is how we improve our own performance. So please do that. Please look into the chat and you'll see learning modules on safe surgery and EPIC. Certificates will be sent on 1st of May to those who have completed the entire session. The materials from this we will send in the next few days. And finally, we have a Facebook community of practice for people who are interested in continuing this dialogue and accessing materials and so on. So that's it from me. Thank you again to all the panelists. Really fantastic session. Really enjoyed it. And thank you to the 500+ people around the world who have participated today. Have a great day, everybody.
Thank you.
Thank you, everyone. Thank you.
Thank you.
Bye-bye.
Thank you. Bye.